is World Suicide Prevention Day, and that is the reason why we are having this webinar with the topic on suicide prevention. So let me just quickly introduce you to our panelists for today. We have our very senior panelist, Dr. Pervin Dadachanji. Pervin, a very warm welcome to this webinar, and it's wonderful catching up again, seeing you after so long. And Pervin is going to talk to us about the work that she's doing in this area, the support group that she's working with. Our second panelist is, of course, a very good friend and someone with whom we've done very many webinars before, Dr. Avinash D'Souza. Avinash also has been working in this field, and in fact, Avinash will start off the webinar with a little masterclass on suicidality and kind of just give a kickstart to the entire session. And our third panelist is a bright young person whom we have with us today, and that is Niana Sabarwal. Niana, if I am not pronouncing your name right, please correct me. Yes. So, am I pronouncing your name right?
Absolutely, you are, and I'm actually shocked. But thank you for.
Okay, so welcome, Niana. Niana is also working in the space of mental health, and she is herself running a support group for the families which have been impacted by suicide. And Niana here has been very kind enough to come onto this platform to share with us her experience, as she is an individual who has been impacted by the loss of a very close family member to suicide. So I would like to thank each and every one of the panelists for joining us here. A very warm welcome. And we will start off with Dr. Avinash D'Souza. So Avinash, can I ask Varsha to start your presentation?
Yes, please.
Yes. Okay. Varsha, can we have Dr. D'Souza's presentation, please?
Yes.
Thank you.
Yes.
Avinash, please do let Varsha know as and when you want to move to your different slides. And, when you are absolutely done, she can then stop the screen sharing. Yeah, thank you.
Sure. Well, good evening, everyone. And the reason we are here today is to talk about suicide prevention, because tomorrow is World Suicide Prevention Day. And my intention over the next 15 to 20 minutes is to take you through certain personal aspects of what suicide prevention means to me. And this is very important because I firmly believe, as a psychiatrist, and I think Dr. Pervin and Dr. Smita Desai also believe, that every suicide is preventable. But it's only that we must act at the right time, and we must know at the right time, and we must also know what to do at that time. Now, coming to suicide prevention, one of the reasons why it's very close to my heart is because I work with schools, and I see a lot of adolescents who are referred to me with suicidal thoughts, with self-injurious behavior. And one of the darkest days for me as a school psychiatrist has been when we've had a young boy who was in the 9th standard who went to a particular teacher on a Saturday afternoon and told her that, "Miss, I want to talk to you." It was nearing the exam, so I think the teacher was very busy with certain exam preparations, so she really couldn't give him the time. So she told him, "This is my number, you call me in the evening, I'll sort of talk to you." Incidentally, the teacher lost her mobile phone in the train. And the boy tried to sort of call her and was unable to reach her because the phone was switched off. And he attempted suicide on Sunday. And we came to know about it only on Monday morning in the school when the parents informed us. And I was very happy that it was an attempt which wasn't a completed suicide because we were able to salvage him, and he of course recovered from that, and then we started counseling. But that is when I think all the teachers in the school realize that the moment a student comes and says, I want to talk to you, we should leave everything and talk to him. That's what is very important. So one of the things is, the moment, one message which I want to clearly give out before we even start the topic is, every suicide is preventable. That is one. And second, that if you ever have an adolescent, a friend, a relative, an elderly person who comes and says that I am feeling not so good and I want to talk to you, just leave everything and say, okay, come, let's talk. Don't worry about, if you miss out on work, don't worry if you miss out on earning some money, but sit and talk to that person and you might probably save a life. Next slide, please. Well, we all know this, and I'm not going to go into too many details because we're all professionals here. But I think it's very important to understand that one of the biggest difficulties in suicide and in suicidology, for that matter, is how do you ascertain who is going to probably attempt suicide? And no one can really give a full-blown guarantee that, no, this patient won't attempt it, or this individual will never be suicidal, or this individual will definitely do it. No, there's no psychiatrist, no mental health professional, no psychologist who can give that guarantee. But what's very, very important to know is some of the risk factors. And some of the risk factors include a previous attempt. It always increases your chances of future attempts, relationship issues, which breakups particularly, access to harmful means. So we always say people like medical personnel, chemists, people with access to firearms, they're all at a greater risk to do this. Recent death of a family member or spouse to whom they were close to, physical disability, substance abuse, presence of a psychiatric condition, ongoing stress either at work or bullying, and losing a friend or a family member to suicide. These are all important risk factors. I know these don't include the entire list, but this is some of the common risk factors that we feel are important. Next slide, please. So what are the warning signs of suicide? It's very important that when people come to you and you talk to them, ask them if they feel lonely. And I think in a city like Mumbai, loneliness is one of the main markers of suicide. Even now in the lockdown, we have seen a spate of suicides amongst our patients, and loneliness has come out as one of the prominent markers that we're finding there. Aggressiveness, yes. Access and possessing lethal means, yes. Always ask them whether they feel hopeless, helpless, and worthless. These are things we have been taught right from our graduation and our post-graduation, and we must ask patients about it. Their low self-esteem. Anyone talking about suicide or making suicidal threats or telling you that I would want to end my life, one of the common myths is that the one who says it probably won't do it, and I think that's the wrong thing. Any suicide any conveying of suicidal thoughts, any conveying of suicidal threats has to be taken very seriously. Similarly, substance use, yes. If a person gives away things, makes a will, makes funeral arrangements, these are all important warning signs that one must feel. If they talk about death, anybody who engages in self-harm, and let me tell you, non-suicidal self-injury is very, very common in today's era. So anybody with non-suicidal self-injury is more likely to attempt suicide when under stress. So these are just the warning signs. Next slide. This is a quote by Emil Durkheim. Emil Durkheim was one of the pioneers in suicidology, and he mentions that every victim of suicide gives his act a personal stamp, which expresses his temperament, the special conditions in which he's involved, and which consequently cannot be explained by social and general causes of the phenomenon. So what we're trying to convey here is every person with a suicide attempt does so because he finds that particular phenomenon, event, particular state that he's in stressful. Someone else may say, oh, there was nothing so stressful about his life. Why did he have to go and attempt it? No, but we have to understand that each person's vulnerability, each person's resilience is different. One more thing which I want to convey to all of you, and I think that's a very important thing to realize, is that don't ever think that, this person looks quite tough, he won't probably attempt suicide. Anyone is vulnerable. So do not ever think that, okay, someone is well to do, someone is probably well in a good job, so the chances that he will probably attempt suicide is minimal. No, we give everyone the same uh, risk. We give everyone the same chance that yes, suicidality can occur. So that's a very important thing. Next slide. Yes. Now, this is a quote which I found, which I put in here because we have a lot of cultural issues also in suicide that are very important. And we keep hearing about farmer suicides because of deaths and financial reasons. So this is a quote by Zeenat Parveen, who's an author, and who's written that the irony is India is not only known for its farming, but is also known for the highest suicide rate of farmers. Now, this is an issue where a lot of my friends who are colleagues and psychiatrists working in areas where farming is the main profession, they have been dealing and grappling with this problem. But the reason I put this here is that financial stress also, according to me, is a common harbinger of suicide. And in today's era, particularly with the economic recession, the lockdown, multiple businesses have failed, startups have failed, people have taken loans, there's no way they can repay them. Suicide rates are bound to go up. Depression is definitely hitting the ceiling, and suicidality goes hand in hand with it. Next slide. What is very important is everyone knows about suicide. Everyone talks about suicide. Everyone is aware what suicidality is. But what are we doing to prevent it? We celebrate World Suicide Prevention Day. We celebrate Suicide Prevention Month. But I believe suicide prevention is a round-the-year activity. It is something that we have to do round the year, and we do it in schools. We keep shouting and we keep telling adolescents that if you feel suicidal, please come and see us. We keep telling our patients, if you feel suicidal, come and tell us. In every mental health awareness program, we say, if you feel suicidal, come and tell us. But the thing is, one of the main reasons why suicide is missed is the stigma of seeking help for mental health problems. A lot of people feel, oh, I am not mad to go to a psychologist or a psychiatrist or a therapist, and I can manage on my own. That is the biggest irony that a lot of people feel. They feel their self-esteem will become less. They will look small in front of themselves if they seek help. Please tell people, seek help from a mental health professional. You may save a life. Next slide. It's also very important that we give our patients a lot of hope. And I feel hope is a very, very wonderful thing that you can give people. So, I mean, I always tell all my patients, don't worry, you will recover, you will get fine. You know, I have had a few therapists, I think, who have told the patient, you know, you have a personality disorder and it's a lifelong condition and you probably are not going to recover and you have to learn to live with the personality. That's a fact. I don't say no, but I still tell the person that you still can change your personality if you wish to. You can still adapt. Human beings are the most adaptable of all species. So we can adapt. Your personality can mellow. It can change. And there is hope for you. Give people hope. There is always hope available. Next slide. And it's very important to tell people to keep going. There are times when I have called a patient 3 times a week, not to charge him. I've called him 3 times a week so that I see him, so that he's in touch with me constantly. Even in the lockdown, there are patients who probably phone me just for 2 minutes on a video call daily, so that I make sure since he's alone, nothing should go wrong with him. And I motivate him to keep going. It's very important that we have to motivate our patients to keep going. There are times when I have messaged a patient in the morning, you know, how was your day yesterday? And he gets shocked that, you know, as a doctor, I mean, I've never had a doctor who's messaged me. And I said, no, it's my job to see how you're doing. I mean, I'm your therapist, so I would want to inquire. Some people may argue that, well, therapists don't do that, but that's my way of probably bonding and looking after patients who are with me in therapy. Next slide. And it's very important that we teach people to believe in themselves. A lot of the times, the reason suicide happens is people have lost belief in themselves. The whole aim of our therapy is to reinstill that belief that life is going to be fine. Next. Well, this is a beautiful quote I found online and I put it. Place your hand over your heart. Do you feel that? That's called purpose. And you're alive for a reason. Don't forget it. I use this a lot in my therapy sessions also. I make the patient feel his heartbeat, his pulse, and tell him, why are you living? And I help him find some meaning to live for. And then accordingly, he finds a reason to live. and death and thoughts of death slowly slip away from his mind. Next slide. So life has its ups and downs. I think we are all been through a very, very rocky ride this year, and I think it will go on probably to early next year, but we have to keep swinging. We have our ups and downs. We can't give up. We can't say it's the end of the world. No. And we have to manage. So the important thing is people have to learn to keep swinging. Next. Every suicide is preventable. I always said this in the beginning, and I'm saying this even now. What's very, very important is, I think a very important thing that I want to tell you today is suicide has been a phenomenon that has been there since mankind itself. Suicide has been mentioned in all cultures, all religions. We have done a lot to prevent suicide. But sadly, suicide rates over the last 100 years haven't reduced. This is a big thing that we have to think about. Why is it that we haven't been able to reduce suicide rates? Where have we failed in our interventions? Probably we need to be innovative. We need to think of new methods. We need to think of new ways. I remember you have to find innovative ways to connect with people. We did a seminar on stress. The RTO asked us to do a seminar on stress for rickshaw drivers. And I know I used the rickshaw petrol meter to explain to them suicidality being the red part where the petrol is over. Similarly, when you give up in life. So, and a lot of them understood. So sometimes you have to use innovative methods. You have to use methods which are different, and you can't make it serious. It sometimes has to be even jovial so that people understand and accept. Even with adolescents, you have to use innovative methods. You may use a video game at times to help them understand sacrifice, to help them understand sharing, so that they learn. But the bottom line is every suicide is preventable. Next slide. Yes, that's all I wanted to convey, because I feel suicide prevention, we are all doing our bits, and we all need to continue doing our bits, and together we can make a difference. Thank you.
Right. So thanks again, Avinash, for putting together this presentation, and I think speaking from your experience, because I think that's what professionals in the field are able to bring. However, I am now going to invite our youngest panelist, yes, Niana. Niana, if I may start off with you, because
Yeah.
you have something to tell us from your heart. And I would again like to thank you for agreeing to share a very personal story with us. So, you have been impacted by the suicide of the closest family member one can think of, a parent. And if you can just share with us, your thoughts, your experiences, I think, that's something that, it's a learning that we will go away with like nothing else. So over to you, Niam.
Thank you, Smita. So I don't know really how to begin, but I lost my parent, my mom, to suicide several years ago. It would be 25 years actually this year. And the loss of suicide is almost is extremely different as compared to, I think, the loss to, an illness or what we consider natural causes. Reason being, I think, is that when you lose somebody to suicide, it feels just like yesterday. And every time you think of the person, it comes back to you in the memories like it just happened yesterday. There are a lot of things that are, I think, attached to a death by suicide that doesn't really happen in natural causes, even though you go through the same probably stages of grief, whether it's anger or, denial and things like that. But most importantly, I think it's the fact that you're left back with this question of why. Why would somebody you love or they love you, why would they choose to take their life? And what could have possibly been so bad? What could have been so wrong that they needed to take their own life, because the idea of taking your life is just, I mean, unfathomable, right? And then when it is somebody that you love and is so, close to you, it's like your parent or your child, you start, wondering what happened. And you live with the question of why, and you never really get an answer, because that's gone with the person, to be honest. And you just, I don't think, ever understand the level of suffering that person is in. And you keep racking your brain year after year, time after time, uh, to answer that question, why. And for most part, we've realized, or I realize, is that you're doing it on your own, because what happens with suicide is somehow, throws you into this deep ocean of silence and isolation. People in the family don't necessarily want to talk about it or bring it out. There is, there's just no photographs, no conversations, nothing that happens about that person. It's almost like the person never existed. You never talk about them again. So then you're just left with all these thoughts and questions and memories and all of those things just with yourself, because there's nobody else who's accessible to really talk about it. And then you're thinking that, let me go back and try to connect the dots. And something that Dr. Avinash said, which is so true, is that, people do tell you that they want to take their life. But it is so impossible to believe that somebody like your parent, would want to take their life, or your child, or, you just don't believe they're going to do it. Even though, like, growing up, I was 13 when she passed away. She told me many times that someday when you come, I may not be there, and during that time, another child in the school had lost their mother as well. And she would tell me that, about that child, one day when you come home, maybe I won't be there. And as a child, I could never imagine that my mother would leave me and go. That such a thing was even possible, even though she almost tried to prep, uh, to know that one day it shouldn't come as a surprise. But it was the worst, I think, thing that anybody can ever face. So the burden of the loss, of the guilt, of the questions, of knowing that actually they did tell you and there was nothing that was done, that, we didn't, there was nothing that, I mean, we didn't believe that the person would do it, so no action was not even been taken during that time. And being a child, I don't think I even understood that there was any action or, any of that. And then comes the whole thing about the way society looks at it, and the isolation that you experience as a member of society. You know that when you're walking past, people will be making comments. They have a character assassination that goes on. That is the family that does suicide, and there's something different about them. So you tell your children not to hang out with them, and you tell them, don't go to their house, or so it's a naturally isolating sort of a process that happens. So much so that people even come up to you and tell you, oh, what a selfish act, they were such a coward. And growing up, you hear these things about your parents, and you're like, that's not true, you know and you're constantly fighting against not just yourself but the world, to say that it must have been such a huge step for somebody to take. What level of helplessness and hopelessness must she have felt, or anybody else who attempts or dies by suicide? um, and how can we not, like, respond? So as somebody who lost a very, very, very dear person, um, I think the most important thing is to say that it is preventable. And when somebody is telling us we have to take action, there's no other, there's no way out, and there's no point in believing they're not going to, because if they are letting you know, they're possibly going to attempt, you know. So yeah.
Thank you very much, for sharing. And I just think it takes so much courage for a family member, especially when it is a parent, like you said, a parent or a child who's done it. Um, I cannot say I empathize because I'm not in that situation, so I'll never really understand. But I'm extremely thankful to you to, be coming on to our webinar and to be talking about such a sensitive thing. And like I spoke to you that day, I think you're one of those few people who even have gone ahead and done something, in this area so as to be able to help other people, which is what, we will be talking about very soon. So thank you very much, Liana. Greatly appreciative of your contribution in sharing this with us. Thank you very
Thank
much.
you.
Thank you. Dr. Pervin, my next question would be to you. I think you've been very involved in running a support group, for families, and in terms of what can be done with families next. So could you share with us a little bit about the work that you're doing and the role that you play as a psychiatrist for the support group?
Um, Hello, everybody. Thanks, Nayana. Every time you share this, every time I am overwhelmed. I mean, I've heard you in so many different forums, and I still get overwhelmed by your experience. So, what happened was, Smita, Nayana and another friend of hers, who
Mm-hmm.
I have seen in my practice at different times. I think, Nayana, when you were, what, 19 or so?
Actually, first when mom passed away, 13 was when I came
So,
to
right. So she
US.
was probably one of my first patients because I mean I started my practice around 26 years back.
Yes.
So
Yes.
so she and her friend at different times had spoken about it that, we don't have any kind of help for people who have lost loved ones to suicide. And
Hmm.
then the two of them got together and came to me and said that, can we do something? So I told them, okay, let's look at what we can do. We can at least start off something. And I think we did a lot of brainstorming sessions over coffee and biscuits and whatever. And then we decided that let's at least start the process going because we were certain that there would be lots of roadblocks in this in terms of people not coming, etc. And so then we decided on the name We Hear You. If you condense it, it becomes why, which is, as Nayana said, that's
Hmm.
the question which one always asks, right? Why
Grapples with.
did you
Right.
have to leave me and go away?
Right.
So we started this in, it's been what, 2.5 years? Two and a half or 3 years?
Hmm.
And we started with around 4 or 5 people, and we made it very clear to. In fact, the other person who is a part of our group, she was very clear that she was not going to talk about anything. She could not. She was just too overwhelmed by what had happened in her family. So that
Okay.
was the thing when we had the support group that people did not need to talk about their, uh, what they'd gone through. They could just
Right.
sit, listen to others, and whenever they felt comfortable, they could. So
Right.
it has been quite a journey. We have had issues in terms of people not, we've not had as many people as we would expect. I mean, all of us know of people who have lost loved ones and we've approached them, but some would say that no, this was, we've told everyone that it was not a suicide, it was an accident, so then they would not want to come.
Right.
There was the stigma attached to it, etc. But I think we have come a long way in terms of the people who have been in the group and what they share with us about how they have evolved over a period of 2.5 years or so.
Right.
My
Right.
role here, actually, I'm a fraud. I'm not supposed to be there in the support group because technically a support group is about people who have shared the same life experience.
Right.
I
Right.
always tell them like I'm cheating, but the only thing is that I have dealt with so many people and families who have lost loved ones to suicide.
Right.
So I have a
Right.
very outside view of it, but it's still
Right.
there. So
Right.
we made it very clear. I think I'm answering other questions also, Smita, which you would have, but I'm sort of putting
Right.
it together that my role here in this group
Yeah.
is not of a psychiatrist, not
Okay.
of a therapist, because we want to make it very clear that a support group is only for support. It is not a
Which is why
therapy.
I asked you this. Yeah. Yeah. Right.
It's not a therapeutic group. So I over
Right.
there am not doing therapy. I am just sitting there and
Listening.
either facilitating or just being just a member of the group.
Right. So if I understand that right, Pavin, what you're saying is that you're more of a facilitator to the group, right?
Right. Yeah.
Rather than being there as a therapist, because as you very rightly said, a support group is supposed to be comprised of those who've been impacted by it, and you're able to facilitate them. All right. Okay. So, Avinash, my next question is to you. Like you mentioned, you have been working in schools. I mean, the two of us also have been, through the years working together with teenagers, young adults, etc. What kind of persons might you be, most concerned about as being at risk for suicide? Specifically, I'm talking about this young population where, we know that the highest rate of suicide, or at least research tells us the highest rate of suicide is supposed to be between 15 to 29 years. So what kind of persons, is there a personality profile? I'm not saying something in literature, but I'm saying through your own experiences, and you yourself are a very scientific person. You've written so many papers. So what kind of persons would you be most concerned as being at risk?
See, I think one of the major factors that plays a role is the family constellation, and the kind of family relationships they share, which is a very important factor, because the lack of social support and the lack of support from family members is one of the main reasons which drives them to do something like this, because they have no one to turn to. Even if they have a single member that is supportive, it's a huge protective factor. Second thing that also is something which comes to light is particularly children who probably are academically having some difficulties, or there has been a lot of bullying in school, or there's been a lot of cyber bullying.
Avinash, I think you're on mute. You might have gone on mute. I'm not so sure, but we didn't hear the last thing.
No, I am fairly on. Yeah.
You can hear him.
Yeah.
You can hear him.
Okay, I will just repeat the last sentence. So, the second group of people is people who either are having academic difficulties, but not understood by their parents or teachers. And we also have people who undergo a lot of
Avinash,
bullying.
I'll just ask you to stop a minute because I'm not able to hear you. I don't know if Pavin, can you hear Avinash?
Yes, I can hear. I can
Okay,
hear.
so maybe I am having a problem. If you can just give me a minute. Okay, Avinash, please continue.
Yeah. So,
Thank you. Yeah. Now I can.
yeah, the group of people that is there is the academic difficulties, particularly those who are not understood by their teachers and peers. I think a lot of bullying that happens in school. And today, I think one phenomenon which destroys the adolescent is cyberbullying. Because if someone posts something very negative on social media, or nude images which are posted, and I think one component of cyberbullying is when your peers sometimes post a photo of you on a pornographic site, which becomes very troublesome for the adolescent. That is something which we are seeing a lot now in the last 2-3 years or 5 years more. And that's there. And apart from that, I think a failed relationship, particularly between the age of say 14 and 18 or 19, which is their first breakup, and it's very often the rejection quotient. Facing that rejection is something which is very, very difficult, because they see the same girl or boy who has said no to them with another person in the same environment, and that causes them a lot of thing. Now, apart from this, I think one thing which also matters a lot is adolescents with substance use, particularly who have been treated very badly by their family when the substance use is detected. So when they are, not brought for help, or not sort of brought for, not handled in the right manner. So I think these are all factors. And I think another risk factor is adolescents that engage in self-injury. This is a particularly vulnerable group that may take that step ahead towards suicide. And we also see some accidental suicidal attempts in these people. So they try to self-injure, but they end up cutting too deep, or they end up cutting, a wrist or something. And then but then they realize, they rush to the hospital themselves. But the thing is, this does happen here.
Okay. So, Niana, over to you. And I believe now you are yourself running an active support group. Yes.
Yeah.
And I think there is some other work also that you're doing. If you could tell us about, this support group and the work, you're doing, which is revolving around the area of suicide, because that's our topic for today. If you can share the kind of work you're doing, and how did you actually get there? I know that it would have, of course, come from your own life experiences, but generally, how has been your journey? What have been your thoughts and feelings on this? So if you could just share that with us.
Sure. So this is actually the support group that Pervin is a co-founder of as well. And honestly, we couldn't have done it without her, because like she said that when I was 13, I actually went to her for the first time. That was when I lost my mom. But subsequently, like she mentioned, that families don't end up actually saying that somebody died by suicide. So much like that, my family tried to tell everyone that my mom died by natural causes, which was an asthma attack. And that's the story that I went with, no matter who the person was. So when one of my dear friends that Pervin talked about as well lost her parent to suicide, that was the first time in I think 15 years of knowing her did I ever tell her that, look, I've experienced the same loss. And over several conversations and just cathartic sharing, we realized that for the first time in our life, we felt that somebody else understood this loss, or that wasn't telling us that, telling me or her for that matter, that, hey, it's been so long, why are you still talking about it, or why do you still feel the loss? I mean, it's a loss that never goes. There are things like, you still remember the last way you saw them, which is something that will never leave your mind ever, especially if you're the first person to go into the room post the attempt, and there is the death. So those are images that never leave you, never. It's something that stays with you always. And when we were able to really share that, we said, why not do something about it, because there will be other people like us. And that's when we approached Pervin. And like she said, over several conversations, later, we decided to set up We Hear You. We also connected with an organization in the UK who helped us kind of understand what a support group looks like and how is peer support group, which is when we realized that it won't be therapy, it will be Pervin facilitating, and she's pretty much the anchor of the group. And like the fact that she does understand the loss, and she has worked with a lot of people, and both of us had been to her, and it was kind of like our own safe space to talk about it. And when she said that, yes, let's do it, that's how We Hear You began. But when I was working with this group in the UK, the one thing that they said was that people who lose someone to suicide, and as Avinash, Dr. D'Souza said earlier, are also at risk, and almost 60% are at risk. So one of the things that came to me was, of course, there is Pervin, but if somebody was thinking, how would we even know? And that's when my own journey and study of suicide began from the perspective of suicidology. And I went and got trained as a first responder to really know the signs, how to do a crisis intervention, safety plan for the person, and to keep them safe. And eventually, once that's done, then to get them psychiatric help and therapy, because it's, again, not therapy, it's first response. And after doing that, I think my whole perspective and understanding of suicide, after studying it and all of those things, I realized how preventable it was, how the signs my mom gave out, my own understanding and journey of it, and that how every family member or every teacher or every person in an office should actually know the signs, so that we don't respond in a way that is either further isolating or neglecting or rejecting the person at risk. And so, we hear you looks at supporting individuals post the loss, but the question is, why should we even be there? If it is preventable, then why do we have people like us in this room? That was the constant question I had. We should not be here. There should be no death then by suicide. And that's when the first response began, as, that we really want as many people, no matter who you are, to recognize that suicide is preventable. It's like Dr. Avinash said, it's an everyday thing. We are all responsible, to put things away when somebody says, hey, I need to talk, there's something not okay with me, I'm having these. And that we don't feel that we need to either reject it or say, what's wrong with you? Don't talk crap, don't talk shit, get over it. Or, you have such a lovely family. Because there are lots of things like trauma and aspects of childhood that we don't talk about that leads to thoughts of suicide and behavior. Which if we become more educated and aware as a society, then people like us don't need to actually be there in a room. So that's really the idea.
Thank you so much. Thank you, Niana. Avinash, from what Niana was saying, and like she said, it's can we predict? We talk about it being preventable. So, Avinash, what are your thoughts? I mean, can one really predict? And if so, then what are some very important warning signs we are looking at?
Well, I think the most important facet is that I mean, I think Madam Paveen will agree with me that as mental health professionals who have dealt with suicidal clients over the years, I mean, we develop a gut instinct sometimes, where we know that, this patient is the dangerous one. So that, I think, is the first thing. So the moment we interview him, the moment we finished our first session of history taking, we know that, this patient is at risk.
It's almost like instinctive.
Yeah, it's done. That is one aspect. I'm not saying that's the only way, but I think other than that, of course, if you have a patient talking about it, you have a patient mentioning it, you have a history of suicidal attempts in the family, and the psychopathology is that intense. So I think you realize that there is probably a risk, and you warn family members. I always say it's better to warn. I mean, don't refrain from warning, even though nothing may happen. So I would say warn more. So I always say that even if you feel there's even a 1% risk, just warn. This can happen. Please be with him. Don't leave him alone. Don't leave the medicines with him. All those things have to be told, and I even write it on the prescription pad, so it's written. It's something which I feel is very important from a documentation point of view.
Okay.
And the last thing that I think is also there, important risk factor is, I think in your history taking, the moment you ask a patient about suicide and suicidality, I mean, I think when you observe his face, you'll realize, whether what is his thought. So you will have a patient who point blank will say, no, I have never been that thinking about that. But then you'll have someone who will, give you that little wry smile and say, yes, it's a thought that does come, but I have never really, acted on it. But nevertheless, then that's your first sign that, this is someone who I have to closely monitor.
Right. Thank you, Avinash. Pavan, that same question over to you. I mean, about this predictability. I mean, what is, what are your thoughts on this? What is your experiences in this?
So, as Avinash said, what I would look at first is to ask each and every patient if they feel that life is not worth living. I
Okay.
mean, it's a given now that one asks that because, and then sometimes, when you ask them, do you feel like committing suicide, maybe they will say no. But if you start from the point of do you feel that life is not worth living, and then sort of progress from there. So I think that is really important to ask. And if there are any therapists on the group, even if you feel that there is no way this person is suicidal, it's always good to ask. You'll get that answer no, but you have asked because it can open a conversation, it can open a whole can of worms. Also, I am also very worried about kids who self harm, because that is the minute they are harming themselves. Of course, a lot of times children who self harm are not wanting to end their life. They very clearly are able to say that I don't want to kill myself. I'm doing it because I want the pain to end. Or I'm feeling like yesterday I had a girl who was telling me that I can bear the sadness, but I can't bear the numbness. So I need to cut just to get that numbness out of the way. So therefore she cuts, but she doesn't want to kill herself. She's doing it in whatever way as a self-protection. I think also to look at family history, that is one of my major things which I look at, that if there is a family history of mental illness, then the chances of the person having that mental illness, depression, suicide, etc. And history of previous attempts, what Avinash was also saying, I mean, whatever he said, I'm just adding on the other things. So there, and as he puts it, that, within a little while, you can know that, oh God, this is going to be someone who is, as he puts it, dangerous, in the sense that there is a chance that they are going to harm themselves. I guess over a period of time, one realizes that.
Can you hear me? I was having a little difficulty in listening. Okay, all right. So, my next question is to you, only to continue from there, Pervin. And that is that, we hear, I mean, we get to know about the suicide bereaved families. Now, how is bereavement different from those families impacted by suicide than families impacted by death through, other events?
Yeah.
Yes.
So it is, I think it is definitely different, because first of all, just the nature of the event or the bereavement is different, because that person has died suddenly. Violent means voluntarily. So all that causes a lot of different kinds of emotions in people. So I will just run you through some of the things which are very different. So one of the things which is really different, like, and I'm also going to talk about it based on, my experiences with patients. So there is a lot of guilt attached. Now, Nayana also spoke about it, that, she said so many times. I recently had a lady whose husband ended his life. And just before he did that, she and he had a fight, and she said, you just leave me and go away. And he ended his life. So in her, that guilt is terrible. So that degree of guilt which is there is, it just is, corroding to the person. In certain cases, especially where there has been a mental illness in that person who has ended her life, the family members have gone through various ups and downs with that person. So in fact, in our group, we have had a person whose brother ended his life, and she said that what she felt was relief. when he did it, because otherwise every single day she would come back from school, there would be that fear that, oh God, is he going to have done something today, because he had done it so often in the past. And that relief then leads to guilt, because how can you tell someone that I'm so happy my brother ended his life? So it is a very different kind of grieving that people who have lost loved ones do. Then there is also the whole anguish and the longing, which is why we are very careful about people when they've been bereaved by suicide, that they may do the same thing, because that longing to be with the person, Then that other thing which Nayana said, that feeling of anger, that was I not worth living for? Was I not worth it that you had to go and leave me? So that is also a different degree than regular bereavement. And then, of course, is the isolation, which, when you have a loved one, I mean, when someone dies, due to natural causes or even unnatural, like a accident, you'll have everyone milling around you. When they meet you, they will placate with you, they will talk about it. But if you have lost a loved one to suicide, there's often silence. And it is not, in fact, in our support groups, we've often talked about it, that people are silent, or your friends or your family are silent, not because they don't care, but because they don't know how to speak about it. They don't know how to reach out, because I think we never talk about death, do we, in any form? It is never spoken about. So often people don't know how to deal with it, but the person who's bereaved will think that, that they are probably blaming me because I was the wife and I could have done something about it. They've heard me and him fighting, so they think that I am responsible. So that makes the person get more and more isolated from everyone. And then there is the whole stigma attached, right? That, this is suicide, so obviously something is wrong in the family. I think there is also this whole thing where we're not going to look at the boy in this household for my daughter because his mother ended her life, so forget it, So it's a complete different, the emotions are totally different, and especially upsetting, because it's like you have been bereaved, you're feeling awful, and then you just feel that nobody understands. Also, in the same family, people do that, right? Everyone isolates themselves, putting photographs away. Oh no, we don't want our children to see. I had a family where the husband had ended his life, and the mother, in fact, the mother's sister had phoned me to say that, this is what has happened. What do we do? And she said, we've put away all the father's pictures because, the little 2-year-old or 3-year-old, whatever, should not see it. So people respond in different ways. One of our people in our support group was saying that till date, and it's been maybe 20 years since her brother died, the family has never spoken about him. It's as though he never existed. So it's very difficult. It's a really difficult and a different gamut of emotions which come up.
I think that's what comes across very strongly from your response, and I think that's something that the audience can take away, and that is all those different emotions, right from, like you said, anger, guilt, shame, stigma, being isolated, which otherwise, is not accompanied by death due to illness or disease or, things like that. So, there is a question on chat, and that's, I think, a worthwhile question, and that comes from Purvi, and that is, I had a question. It does not happen like when you ask a person if they feel life is worthless, or they feel like suiciding, or any other question to suicide. Isn't it possible that they have never thought of attempting suicide and think of it after you've asked them, and then they start thinking about it? Avinash, what's your response? And I'm probably going to take this response from each one of you, because I'm sure each one of you has,
Yes.
because this is a very asked question.
Okay. Well, Purvi, you're not alone who asked this question, and I think uh, when I was a very young psychiatrist, maybe 20 years ago, I asked my father this. That if I ask all my patients about suicide, what if I plant the thought in their mind? And he told me that if you ask them a history of thyroid problems, they don't get thyroid, or you ask them a history of blood pressure, they don't get blood pressure. So he
Very
said,
true.
your job is to ask everyone because you may save a life. It's as simple as that. And even if it means that, in fact, I look at it the other way. You may be the first person who's ever asked him, and he may really feel that you have actually asked me this which is going on in my head for so long, but none of my counselors or none of my other people have ever asked me. And now that you asked me, yes, I know I'm going to get help, and I'm very happy that I don't want to end my life. And very often I know I've asked patients who told me, I have thought about this, but then I have a family, I have a son, I have parents, so I know I won't do it. But it's a thought that comes, but then you still know, yes, that means the thought comes means immediately it indicates that this is severe depression, which needs to be treated and handled in a more aggressive manner. And all your antennas go up. So you tell the family members not to leave him alone, you tell someone to accompany him, you tell him not to drive alone to work. I mean, multiple things which is always advisable. Also, what I always tell my students at an MA level and at an MD psychiatry level is practice asking this in front of the mirror and see your own face. Very often we get a little uncomfortable when you're young asking these questions. So you have to learn to practice and ask in English, Hindi, Marathi, because you're staying in a city like Bombay. So you must know how to pose these questions to different patients. And you will have to differentiate, I mean, even like someone told me that, how even if he says he has felt suicidal, how do I ask him, has he ever tried to attempt? So I said, it's a simple thing. You have to ask him, have you ever tried to act upon your thoughts? And he will answer. You don't necessarily tell him, have you kabhi attempt kiya hai kya? You don't have to sound, very rude in that manner. You have to learn how to word your questions. And I think the patient, and I think ask every patient. I always say, don't ever worry. It's like, this is like in schools where parents say, if we have sex education sessions, will the children get promiscuous? They won't. I mean, I think it's they would rather have the information from us. It's better than going and getting it from the watchman or driver. So here I feel it's better that it's important that they sort of we ask. You must ask. So I mean, Purvi, your question is very valid, but I think you have to ask everyone. There's no choice.
So Avinash, I know that you have another engagement and you need
Yes.
to leave in another 2-3 minutes.
Yes.
So I'm going to put my last question to for you to you, and then I will actually take the same question to Pervin and to Niana. And my question to you is that we do keep talking about prevention, right? So what are your what might be, like, say, 1 or 2 strategies for prevention? Or if there has been only an attempt and the person has fortunately not not actually been faced death due to this, what should be the next things that are done
Well,
done for this individual?
yes, I think the most important thing is talking about suicide, and suicide prevention, because not many people talk about it. And so that's something which is very, very important. And I think another very, very important facet which matters in suicide prevention is to cater to different sections, which we don't do. So the focus is always on school children, but we one thing which we miss out is elderly suicide is very common, and that is not looked after at all. And we never think of suicide in middle age. I think suicide prevention has to be done at the workplace, in the school, for older people, for younger people, for everyone. And like Niana runs the support group, I mean, I think no one has ever done anything for the family members who have survived the suicide. So that is also a very important area, because especially in the acute phase, taking care of them is very important. See, they all probably would cope with their own resilience over 6 months to 1 year, but that acute 6 months to 1 year of support which they need is very, very essential. So there are multiple subsets, and even suicide prevention, I mean, probably the way you do it with, say, an educated community versus the way we do it in Dharavi when I work with Sion Hospital is very different. So, you have to look socio-culturally, a lot of factors matter. So I think, so that is one thing which I would advise. Secondly, I think anyone and everyone who has, had an attempt, and this is something which Dr. Nilesha, our HOD, always has taught us, that कोई भी अपनी जान ऐसे ही नहीं लेता है, उसकी भी कुछ मजबूरियां होगी, so no one enjoys taking his life. So don't think कि he's a borderline personality, he is going to do this, and it is, and have that bias when you go to him. No, even a person with personality disorder has issues which are causing him, the tendency is, the moment we put a diagnosis of borderline personality, many people think, oh, this is all part and parcel of the illness, so even if they attempt suicide, wo to karega hi, it is borderline. We don't, I think that bias in our mind also has to go. So every attempt has to be looked at seriously. And I think, and another thing I will want to mention here, particularly since a lot of mental health professionals are there, I'm sorry I'm taking up a little time, is that in therapy, if you have a patient that attempts suicide while in therapy with you, I think please do not, lose your self-esteem as a mental health professional. These things do happen, and it may not be that you have said something or done something which has led to this. I mean, the attempt may have happened even otherwise, and there are acute stresses that cause the attempt. So I know a lot of psychologists who say that, I think I don't want to take this patient up further and I'll refer to someone else. I think, in fact, you should take it up as a challenge and make sure that future attempts don't happen. So I think don't give up the patient. Yes, we medicate him, we treat him simultaneously, but don't give up therapy thinking that, oh, I have probably failed as a therapist. No, you haven't. These things happen. Yeah. Thank you. Yeah.
Avinash, can I ask you one question before you leave?
Yes.
Okay. All right. So, we've been talking about these warning signs, prevention, all of that. Now, suppose, you just have, Pervin, you all have, patients coming in with different mental health issues, right? When is it? What is it that strikes you, that gets you to ask this question? Either a question that Pervin said, the way she framed it, or the question that you say, have you ever thought of acting on your thoughts, or, have you ever thought of this, taking your life, whatever it is. What is it in that patient that prompts you to ask that question?
I think we ask every patient. I don't think it's about, being prompted whether to ask him or ask her or not ask him. I think we ask everyone that, if you ever felt suicidal, yes. If they've said no, then it's okay. Then, the algorithm changes. We go to another line of questioning. But the moment they say yes, have you acted upon your thoughts? That's the very next question we will ask without thinking.
Right. I'm glad that you clarified that. And
Yes.
with that, you are free to leave for your other
Yes.
engagement. Thank you for joining. And
Yes.
I will continue with Pervin and
I will
Liana.
just mention that I'm very happy to see Pervin ma'am after a very long time. So yes, so that's thank you. Yeah, okay.
Right,
Yeah,
right.
sure,
And
yeah.
I think we must all thank Avinash, because Avinash is the one who actually connected me to you. I mean, although you and I have known each other for so long, but I didn't know that you're working with the support group. And I think from there we went on to Niana. So it's wonderful, all of us getting together, and the group that we have on the platform. I'm sure they've got wonderful things to take away today from this panel that we have. So thanks, Avinash.
Yeah. Yeah.
Avinash, doing another program 2 weeks down the line, and that is, we are addressing almost, I would say, another pandemic on dementia. This month also being the awareness month for dementia. So on the 23rd of this month, we are doing a program on dementia, on Alzheimer's. So I will see you again there, Avinash. And so, before I get on to, there is a very interesting question which has come up from Gauri Chaturvedi. But before I go on to her question, Pervin and Niana, first Pervin, then Niana, I still want to take up Purvi's question here, where, by talking about it, are we putting it in someone's mind? What are your thoughts on this? Pervin, you can go
So I
first.
think Avinash hijacked my part that I wanted to say about
Okay.
this head thing, because it is really like that you, just because you talk about sexuality education, are you planting promiscuity in a child? Are you it's exactly the same, because if I don't have the thought, it's not going to be put into my head. Secondly, I think it is a lot to do with our discomfort as mental health professionals, because it's also something like abuse. We are told that we need to ask, but we are so uncomfortable about asking that, have you been sexually abused at a time, at whatever time, or have you felt like ending your life? Because the fear of it opening a can of worms, and for us then to deal with it where we may not be sure that we are able to handle this thing. So to reduce our own discomfort, we say, forget it, she's smiling, yeah? She's just come for a problem, she's been laid off work. Now she is not going to be suicidal. She's got a child, she whatever. So I will not ask. But it just takes that 1 minute to do that. And to add to what Avinash was saying about, asking every person this, it's a part of our training. When we are given our history taking, this question is always there, because you're ruling out disorders, right? You're ruling out depression. So in depression, you will have these questions. When you're ruling out schizophrenia, you will have questions on hallucinations, delusions, work functionality, etc. So it's just like the way you would ask about, how are you? You are asking that, do you think that, you would want to end your life?
Okay, so I think, so I think what we'll do is there are a couple of very interesting questions here. And I think what I'm going to do is, there was first a question by Ankit Singh. And he says that kindly provide your inputs on the latest NCRB suicide report 2019. There's been an increase in suicide by 3.4% over 2018. And the data for 2019 says that males, greater suicide than the females. The male suicide, it is 32.54% only due to family and marital issues, especially the gender bias law, the misuse of law, which is the fuel for mental agony and harassment towards the husband and his family members, that has resulted in an increase in the suicidal rate in males. So even I've been reading about this, greater suicidal rate amongst the males and the females. So, any thoughts on, this latest report and about this male suicide being greater than the female suicide? And then from after that, I will go on to Gauri's question, which is important. I absolutely want to address Gauri's question. So, thoughts on Ankit's question?
I think this has not been something new. We have always had that attempts are more in women, but completed suicides are more in men. Because men use more lethal ways of ending their lives than women do. And I think that is all over the world.
Yeah.
Whether in countries like America, where you shoot yourself, to jumping, to hanging. So the men use more of these. Women do more overdose. In our country, it's more burning themselves, etc. So it has always been that skew has always been. Perhaps it's more, I don't know the percentage, so I would not be able to say that. And then also you have to look at what are the other causes. Maybe, see, substance use is a very common part of suicidal behavior. And when you are in an inebriated state, the chances of you having and having a completing a suicide are far more. Nayana, would you like to add to that? This is what my thing is.
So I think absolutely what you said. It's not been something that's new. It's globally known that men use more lethal means than women, and of course, alcohol being one of the biggest causes for completed deaths by suicide, because it increases it by 25%. So all deaths by suicide, 25% of them happen under the influence of alcohol. So whenever there is a substance abuse issue, there already is a direct link to a high increased chance of attempt or death by suicide in men. And men turn to substance abuse quicker and faster for long term more than women do. So definitely, yeah, that, but this has been something that's been there for the long term. The NCRB report numbers also, if you compare it to the Lancet numbers, you'll see a huge difference. So Lancet says that we lose 285,000 deaths by suicide each year, whereas the NCRB talks about I think 130 to 140,000, and that's a huge difference because of just the way we report suicide in our country, and the way we don't report. So that's like another big part of the number, and actually deaths by suicide in our country are a lot more than what is indicated in the NCRB. But I think the one important thing I want to say here before we go ahead is that suicide is decriminalized, and yet we put the numbers in the National Crime Report Bureau, which I find really the irony of the situation. But really to tell families that when there is an attempt, it's no longer a crime. So please take your loved one to their, a hospital, or if there isn't a psychiatrist, because many times in crisis intervention, that is the one big hurdle and obstacle that we face, that when somebody does attempt and there hasn't been a treating doctor, so then we put them on to one, but they refuse to go to a hospital. So maybe Pawan, I know this is out of this thing, but if you could please share anything with regards to that, because that is something that people still say that it becomes a police thing and stuff like that. So I don't know, Pawan, could you share some light on that?
It is not. So it's a medical legal case, but it is not a criminal case. So police will be involved, because when you go to a hospital, etc. I mean, if a person is dead on arrival, whether it's due to suicide or anything else, it is going to be a medical legal case, but it is not a criminal case. So there is that difference now, which has been found. But of course, then you can make it criminal in terms of abetting and aiding a suicide and all. I think we need to have a lot of things changed in our country, but that's besides the point.
Okay, so I would actually really like to take, there's a very sensitive question, and I am in fact very overwhelmed that, there is someone who's actually speaking about her own attempt, if I'm not mistaken. Yeah. So this is Gauri Chaturvedi, and I would like to thank Gauri for, coming forth and being so bold and sharing this on this platform. And I'm going to read out her message, and I would like both Pervin and Niana to respond to it. Any one of you can go. So if you all read it in the chat also, I'm just going to read it out. I myself have been known as a very strong person, and I'm still known as the most helpful person amongst family and friends. But I myself have attempted suicide not very long back. So how could I not imply my teaching? How could I not use my teaching on myself? I could have saved definitely few of my friends, but neither I myself nor people around could notice any warning signs. So I think what Gauri is doing is asking you for help in terms of, what are some of the warning signs? How is it that perhaps she can help herself in spite of, being known as a strong person, as someone who can be helpful to others? Is that perhaps misleading to others and to themselves? So, Pawan, Liana, whichever of you want to go first on this, I think this is something really sensitive, and, if we can even help Gauri on this platform, that would be wonderful.
What I feel is that for others, so for example, Gauri has that demeanor or that outward thing of being strong. I think for all of us who are her friends or who know her, we and for not only her, for anyone to be able to, so you have a friend who is that strong person who's always there for you, who listens to you, who helps you out. All the friends need to also ask her how she is or how he is. I think that is so it is from the outward from the people around her who need to do that, and also for people who are strong to be able to allow themselves that vulnerability, to be able to reach out and tell someone that I am feeling this way. It doesn't make them weak. I think we look at strong versus weak. We don't look at it's strength which makes you reach out to someone and say, I am not okay. Also, it somewhere I feel that it demeans a relationship when you have your issues but you do not discuss them with your friends because you feel that I have to be the strong one. No, in fact, I think those things equalize relationships. Otherwise, it's always a one-way traffic. So I don't know whether I have been able to give I think, Gauri, what I would really say is for you to reach out and tell people that, I'm also hurting. I can't be that strong, silent type who's always there for everyone and going through this. So communicating that angst is, I think, very important for us.
Thank you so much, Pavan. Thank you. And Niana, your thoughts on this?
Yeah, so I resonate with the difficulty of asking for help. I think it's one of the hardest things, especially when you've grown up believing you're the strong one and you're the one who's supposed to be the one that takes care. And it takes a lot of courage and self-work to say it's okay to ask for help. But if somebody is at risk, I think that if you don't know what the signs are, you will miss them. So actually being educated on what those signs are, and any sign that makes a person behave out of the ordinary from who they are, is a sign to reach out and say, hi, you doing okay? And basically in first response, we kind of teach what that looks like for different people and just in general, and how do you ask the question of, are you thinking of suicide or ending your life, and what do you do thereafter? Because there are certain things everybody says naturally, but there are also things that if you know that person well enough, it's very out of character for them to say. For example, I just sometimes want to sleep and not wake up, or something like that, and you're like, hey, that sounds very unlike you. So there are general signs, but there are also signs that are specific to that person, that as a friend that you can then pick up and say, hey, something doesn't seem okay. But it's actually without actually knowing what I'm looking for, it's very difficult to say that I'm looking for something or I'm looking for a sign. And especially when you're the strong one, you tend to be like, she'll be okay, she'll manage it on her own, until, like Pavan said, really making yourself ask for the help, and it's okay. And by asking for help, you're not being weak. And I can only say that it's easier said than done, from experience, I would say. But it is ever so important that we learn to, actually learn to ask for the help that we need. Because otherwise it's really sometimes difficult for those around to actually pick up on that.
So thank you very much, Niana. I think very nicely put. Yes, Pavan, I just wanted to call another question after this.
No, I just wanted to add over here that, just sharing something. So I have a lot of my patients who I see regularly. Some of them will come in, when they come into my clinic, will ask me that, how are you doing, doc? Because nobody must be asking you that, right? That are you okay? Is everything going well in your life? So I think these are kinds of things which really help us to, gauge what the other person is going through.
Thank you. Thanks, Pavan. And Gauri, I do hope that, what our esteemed panelists have spoken about might be of some help to you. I think it's so brave of you to be able to put this on this program and talk about it. And all our three panelists are people who are working very actively in the field. So, you can reach out to us for their contact details. You can just Google them and they'll all be available. Their contact details will be available. Please do not hesitate if you think you need some kind of help. I think this is the time to go forward and seek this help. you will not only be able to help yourself, but I think also many other people. So I'm going to move on from here to a question by Stella. Stella Carvalho has a very, very good question and a frequently asked question. That sometimes you know that a person is talking about suicide, very likely to do so, but are rigid. They are not willing to visit a psychologist or a psychiatrist. And thus, how can we help that person? What are the actions that we can take in order to help save this person's life if they're not willing to go out and seek formal help? So, any one of you, Parvin, Niana, anyone can go on this.
You can take that.
Yeah.
Sorry,
You want to take that?
please add to it, Bhavin.
Yeah.
But
Yes, absolutely.
so again, we look at it from the perspective of how can a family member or a friend or someone, kind of know how to ask the question and then safety plan for the person so that they can keep the person safe. A lot of times we've seen, yes, there is a resistance to medication, to going to get help, because again, there is what we find, the feeling that nothing's going to change. I've tried everything out and I feel this is it, and which is why we say that, keeping a person safe every single day might require, conversation every single day, safety planning, checking in with them, making sure that family is on board. Sometimes that may go against, because it could be that the issue is a family member. It could be some of those things as well. But really, it is about, I think, if you're choosing to be that support system to that person, it's making sure that it takes patience, it takes a lot of understanding, it takes a lot of compassion. Every day might be a first response day, in the sense that you may have to keep that person safe every single day till they recognize that getting the help that they need will only come when they seek professional help, and that, through that journey of safety planning that we do, which is to kind of understand that, if there are thoughts, have they had, are they thinking more than thoughts between yesterday and today, and what does that mean, and all of those sort of things, to make sure that we're absolutely trying our best to keep them safe. There's no alcohol involved, all of those different elements of a safety plan that we take them through, and to always say that, okay, fine, this is a number of a psychiatrist that I want to keep with you, and that that you give it an opportunity to reach out, and I will be there with you, and I will sit with you on that call, and if you require anything, or if you want me to be there while you're there, I will do it, and you don't need to go alone. What we have found is, I don't want to be told that there is something wrong with me, or that I need to take, those kinds of things that build up resistance. That's what we have seen. Obviously, there is a whole different sort of perspective that Pawan will give. But that is essentially what we have seen, is that I don't want to be told, because I'm not the problem. It's XYZ and, all of these other things that have brought me to this point. And that will only be taken away or resolved or, healed, or all of those sort of things if we are able to get you the help that you need. So kind of getting them to understand that they need the help, rather than me telling them, look, you need to go to see a psychiatrist. It really doesn't work that way. It's like, maybe what are the other things that you think? Have you known of anybody else who's feeling? Do you think it could be depression? Who could help you with that? Do you think, and it's about making sure that it comes from them as well, and they are a part of their journey. Otherwise, they will even sit in front of possibly, in front of help and say, I'm not going to take the medication today, and I won't, and things like that. So we've seen that, and, as well. So I think it's about ensuring that we have the patience, and that we're willing to have that conversation and check in with that person every single day, to keep them safe. So that's
Right. Thank you so much. Pavin, any thought on this? Like, how can we help a person who's refusing
So I
help?
would, just to just say it. I think if you are still, that person is talking to you about it, that in itself is a great thing. So you keep that connection going, because the fact that he's saying that he wants to, or he feels horrible, but he's still talking to you. So there is that thing that he wants to be saved. which I would hang on to and keep the connect going. Sometimes what helps, if you can find another person who may have had a similar experience in the past, instead of taking them straight to a therapist or a psychiatrist, maybe if they are resistant to that, perhaps that would also help. That, I have this friend who went through a similar kind of thing. Would you like to just talk to her about it? Maybe somewhere that, that again becomes like a mini support group, right? It's just that support which you get, that, oh, I have gone through this and I have come out of it. So there is a lot of hope. So you're giving that person the hope that things can be better because someone else has experienced it. So that would be my add to that.
Yeah. So, Parvin, in fact, now that you spoke about it, so typically what we do is that, every webinar that we have, a very similar topic, we follow it up with a workshop over the weekend. So this weekend also, we have a workshop on suicide prevention and risk management, which we had done previously, but we also have it this time. And in fact, what my facilitators also told me is precisely this, that in fact, even in the workshop, there are people who come forward and actually start talking a little bit about, what has been on their mind. Probably no one's even asked them about it. And, they are going through things, but, they probably even join the workshop, wanting to know more and probably having a platform perhaps just to express themselves. So, yeah, I think, the more we break the silence on it, the more we start to talk about it, because like you yourself said, there are families who just kept quiet, and they just, there has been silence for years, and we don't, talk about it. And so, like we put in the chat also, we are having a workshop on risk management and suicide prevention. This is just for the others on the platform. If they wish to attend, it will be, a good closing, kind of a closure in terms of, we look at it in detail. At the end, I would, be close to our ending time, and therefore I would just, request both Niana and Dr. Pavin to give, the people on the platform, our audience on the platform, two takeaways each that they go back with, because these takeaways are, I think, something that people, really can do something to psychoeducate those around them. So, Pawan, any two
So as
takeaways?
you just said, Smita, let's talk about it. I think that is what I would really say. Let's talk about it. And also to,
Okay.
I think somewhere to destigmatize mental illness, to
Right.
make it more about, well, it is a physiological issue. It can be it can be like diabetes. It doesn't have to be about being strong or weak, etc., and therefore seeking help. The minute you destigmatize it, then you feel like if you have diabetes, you'll run to your doctor, because diabetes is not a stigma.
Yeah.
But if you have depression and you want to end your life, you're not going to run to a doctor because there is a stigma attached. In fact, just as a little thing, I think we have in our support group now, because we are doing it online, we have more people. And we can think of one of the things is logistics, yes. But I think the other thing is because you're not entering a psychiatrist's office. You're not, that stigma has been,
So, that's what I feel, that the issue here, with all of these mental illnesses, I think are two things from what I've understood over the years. And that is, we're not, we equate mental illness with weakness. Yeah. And somehow we all feel that we need to be strong, like, someone said, Gauri said, or whatever. We need to be very strong. And the second thing is, it's associated with being ashamed of it. That shame factor, okay? That how can I be weak? How can I have this issue and want to talk? No one minds talking about a heart problem or a diabetes or, even cancer. but we just do not want to talk because we equate it with a weakness with ourselves. So, Niana, over to you for your last words, my dear.
Yeah, so I think I just want to say that um, one thing I learned is that stigma grows in silence. It almost feeds off the silence. So the more quiet we are, the more the stigma grows. We almost give it its power that it seeks. And the more we kind of talk about it, the more it will cease to exist, because then becomes something that can happen to anybody. All this while it happens to that family or that person or a certain kind of person or a certain kind of family. But today we know that mental health, each one of us are at risk. And any one of us can be at risk of, you know, thoughts of suicide as well. And that if we really open our eyes and really want to be people who want to do something about it, then we need to look at the signs, and we need to respond to those signs effectively and immediately, and kind of be that person who listens. you know um, and if we can do that, then we're creating safer spaces in society for us to really able to talk about things that are real, and grief, sadness, loss, anxiety, depression, emotional distress. All of these things are real, and we need to become real. And if you're able to do that, we have a greater chance of thriving, I feel. And that's what I would kind of take away. And the other is, don't suffer alone and don't suffer in silence. There's always help. There is always help, and when you seek it, you will always look back and say, why the hell did I suffer for so long on my own? And if you can't do it alone, reach out, and somebody will be there, somebody will show up, and uh, just take care of yourself, is what I would say.
Thank you very much, Niana. Thank you so much for taking your time. Not only that, for sharing your personal experiences. I think the group here on this platform has gained tremendously from all the panelists, from our senior, from our senior colleagues like Pervin, Avinash, and from you, where it comes from, a person who has been impacted by this. I would request everyone on the platform to please fill out our feedback form. This feedback becomes very important to us because it helps us simply to do things better the next time. And also, of course, gives us very positive strokes. We are always one to give positive strokes and to, look out for achieving them. So thank you, everyone. And, our next webinar, that's next Wednesday. So I'm also looking at different specializations in psychology and how to expose the young people to that. So we're going to be doing that. Next week, we have someone from neuropsychology and from sports psychology whom I'm going to do an interview format on the webinar. And after that is the dementia session with Dr. Avinash again. So look forward to having all of you. And those on this platform, do look forward to, you all joining us on the workshop. I think it's as much as we participate with each other, we talk about these things, we break our silence, we psychoeducate, is the way forward. So, Dr. Pervin, thank you very much. Let's keep in touch. And Niana, I'm surely going to give you a call very soon and look forward to some collaboration with both of you as far as some school populations are concerned. I think it's important to start right over there. Yes? So thanks again to all of you in the audience and the panelists.
Thank you, everyone. Thanks, Nita. Thanks, Anna.
Thanks, Pavan. Thanks, Nita. Thank you, everyone.
Bye-bye. Bye.